Good afternoon and welcome to my very first voiceover video presentation posted to YouTube. The purpose of this video is to provide an overview of the clinician-administered PTSD scale, better known as the CAPS-5. Recently, the CAPS was updated to correlate with the revised PTSD diagnostic criteria in the Diagnostic and Statistics Manual for Mental Health Disorders, or DSM-5. The CAPS-5 is a 30-item structured interview that can be used to make a current or past month diagnosis of PTSD, make a lifetime diagnosis of PTSD, or assess PTSD symptoms over the past week. In addition to assessing the 20 DSM-5 PTSD symptoms, questions in the CAPS-5 target the onset and duration of symptoms, subjective distress, and impact of symptoms on social and occupational functioning. It assesses for the improvement in symptoms since a previous CAPS administration, overall response validity, overall PTSD severity, and specifications for the dissociative subtype, meaning it assesses for depersonalization and derealization if it's present. For each symptom, standardized questions and probes are provided. Administration requires identification of an index traumatic event to serve as the basis for symptom inquiry. This means that throughout the entirety of the interview, a single traumatic event is used to assess for impact and symptomatology. In order to do this, the Life Events Checklist for DSM-5, or the LEC-5, can be used to identify exposure to stressful events that may be related to trauma and to establish criterion A of a potential PTSD diagnosis. There are 3 versions of the Lifetime Events Checklist that are administered differently. Today we'll be using the standard version, which can be self-administered by the client and once completed, provided to the interviewer prior to the full administration of the CAPS. A couple additional details about the CAPS instrument. The CAPS was designed to be administered by clinicians and clinical researchers who have at least a master's degree preparation that involve training in advanced psychiatric instruments and who have a working knowledge of PTSD. The full interview typically takes between 35 to 45 minutes to administer, and psychometric studies have demonstrated that the CAPS is both reliable and has validity for assessment purposes related to PTSD. So today, the objectives of this training video are to review diagnostic criteria for PTSD according to the DSM-5, to describe the key components of the CAPS-5 instrument. This will also include an overview of the Lifetime Events Checklist. To provide an overview of interviewing principles regarded for administering the CAPS. To describe symptom ratings used in the CAPS-5. To provide an overview of scoring of the CAPS-5. And to identify ways to address discrepancies that may arise when you are administering the CAPS. Let's begin with an overview of the current full diagnosis for PTSD. Post-traumatic stress disorder, or PTSD, is a psychiatric disorder which results from exposure to a traumatic event. In order to diagnose for the presence of PTSD, there must be the presence of a traumatic event. A traumatic event involves actual or threatened death, serious injury, or sexual violence. A person can be exposed to a traumatic event in the following ways: by directly experiencing the trauma, by witnessing a trauma, by learning that the traumatic event occurred to a close family member or close friend, or by repeated or extreme exposure to adversive details of someone else's trauma. This happens for people who work in law enforcement, or this can also happen to individuals who are repeatedly exposed to details of childhood sexual abuse. The DSM-5 further clarifies that symptoms must be related to the traumatic event. Specifically, symptoms from criteria B through E, which we will review, must have had their onset or have become significantly exacerbated after exposure to the traumatic event. This is new for the DSM-5. So basically, what the DSM-5 is asking you to do is to determine trauma relatedness of the symptoms. For criteria B, or intrusive recollection criteria, this includes symptoms that are perhaps the most distinctive and readily identifiable symptoms for PTSD. For individuals with PTSD, the traumatic event remains, sometimes for decades or a lifetime, a physiological experience that can often invoke experiences of panic or terror or dread, grief or despair. These emotions manifest during intrusive daytime images of the event, or nightmares, or vivid reenactments known as PTSD flashbacks. Also, trauma-related stimuli that trigger recollections of the original event have the power to evoke mental images, emotional responses, or physiological reactions associated with the trauma. The C criteria, or avoidance criterion, consists of behavioral strategies that people struggling with PTSD use in an attempt to reduce the likelihood that they will expose themselves to a trauma-related stimuli. People with PTSD may use these strategies in an attempt to minimize the intensity of psychological responses or symptoms if they are exposed to such stimuli. Behaviors include avoiding any thoughts or situations, which is likely to elicit distressing traumatic memories. A more extreme manifestation of an avoidance behavior is when a person is afraid to leave the house, may appear as agoraphobic, and fear leaving the house due to confronting reminders of traumatic events. In order to fulfill criteria C, only one avoidance symptom needs to be present. For criteria D, this refers to symptoms including negative cognitions or mood, and reflects persistent alterations in beliefs or mood that have developed after exposure to the traumatic event. People with PTSD often have negative thinking errors about the causes or consequences of the trauma, which leads them to blame themselves or others. For example, a common belief that can occur is that one is inadequate, weak, or permanently changed for the worse since exposure to the traumatic event, or that the future has become permanently altered because of the event. You may hear people say things such as, "Nothing good can ever happen to me," or that no one can be trusted, or that the world is completely dangerous. In addition to negative thoughts about oneself or the world, criteria D symptoms also include negative emotional states or affects that the person may experience, such as anger, guilt, or shame. Other symptoms that fit this criterion involve diminished interest in significant activities and feeling detached from others. Finally, although individuals with PTSD suffer from persistent negative emotions, they are also unable to experience often positive feelings such as love, pleasure, or enjoyment. So rather are kind of devoid of emotions. Such constricted affect can make it difficult for the person to sustain a close relationship with others. For criteria D to be reached, 2 negative symptoms must be present. Criteria E. Symptoms included in criteria E involve symptoms related to alterations in arousal or reactivity. These symptoms most closely resemble those seen in panic or generalized anxiety disorders. While symptoms such as difficulty sleeping and difficulty concentrating are common anxiety symptoms, hypervigilance and heightened startled response are more characteristic of PTSD. The hypervigilance in PTSD may sometimes become so intense it may appear like paranoia. Other components of an arousal symptom for PTSD may include irritable or angry outbursts, and that may be expressed as aggressive behavior in some people. Finally, reckless and self-destructive behavior such as impulsive acts, unsafe sex or reckless driving, and suicidal behavior are newly included in the DSM-5 as criteria E symptoms. Criteria F deals with duration criteria. Symptoms must persist for at least 1 month before PTSD may be diagnosed. This month can have occurred in the past and does not need to be the present month. As mentioned previously, the CAPS-5 has a worst month version that establishes a lifetime presence of PTSD. The final two criteria, criteria G and criteria H, establish functional impairment and address any rule-out criteria. Criteria G establishes functional significance criterion, and that the individual must be experiencing significant social, occupational, or other distress as a result of those reported symptoms. Criteria H is met only if symptoms reported are not due to medication, substance use, or other illness. Two PTSD specifications are included in the DSM-5, delayed expression and dissociative subtype specifications. The full diagnostic criteria for PTSD must be met before either specification can be given. PTSD with a specifier of delayed expression occurs when the full criteria of PTSD had not been met for at least 6 months following the traumatic event. The latency of the expression of PTSD in individuals is well known, with some individuals not meeting PTSD criteria for years after a traumatic event or events. An additional specifier in the DSM-5 for PTSD, and that the CAPS-5 also assesses, is the dissociative subtype specific for PTSD. While there are a multitude of forms of dissociative phenomena, a person with PTSD is classified as a dissociative subtype only when criteria are met for symptoms of depersonalization or derealization. Depersonalization is a form of dissociation that refers to persistent and recurrent experiences of feeling detached from oneself, like a sense of disconnect from the mind or body. Derealization is another type of dissociation, which refers to a persistent or recurrent experience of unreality of surroundings and can be described as a feeling of detachment from the world. So in summary, an individual must meet the following criteria in order to achieve a DSM-5 diagnosis of PTSD. Exposure to a traumatic stressor, exhibit 1 or more intrusion symptoms, exhibit 1 or more avoidance symptoms, exhibit 2 or more persistent negative changes in cognition or mood, exhibit 2 or more alterations in arousal and reactivity, experience symptom duration for at least 1 month, experience clinically significant distress or impairment as a result of the symptoms, and finally, the symptoms are not better explained by substances or other medical diagnoses. Once that criteria is fully met, 2 specifications may be given, if relevant: the delayed expression and/or the dissociative subtype specifier. Now we are going to go on to the CAPS-5, and describe the key components of this clinically administered instrument. If you have a copy of the CAPS-5 instrument currently, it may be helpful to have it out and review it as we go over it. Additionally, there is a completed Lifetime Events Checklist, or LEC-5, that I'll refer to as well. It's been completed ahead of the class so that you may use it with your practice subjects later on today. Please feel free to ask for the video to be paused at any time so that you can ask any questions. The CAPS is the most widely used clinician-administered structured interview for diagnosing and measuring the severity of PTSD. Prior to the CAPS, most clinical interview instruments ask clients to respond to whether or not symptoms were present using a simple yes/no response. The CAPS gets at both the frequency and intensity of the symptoms that the client is reporting. This information is used to determine the level of severity of the symptoms, and I have also found it useful in focusing treatment planning with the client later on. The severity scales can help to target and prioritize the most problematic symptoms during the safety stabilization phase of the phase-oriented approach to trauma therapy. As mentioned previously, the Lifetime Events Checklist, or LEC, can be used to establish criterion A across 7 predetermined items. Each item is a potentially traumatizing event that may have occurred within the client's lifetime. There are 3 versions of the life events checklist. The standard version. This can be self-administered, with the client completing it privately. The client checks at least one box for each event and indicates whether the event applies to them or not, and if so, the nature of the exposure. Did the event happen directly to the client? Did they witness it? Did they learn about it? Did it occur as part of the job? Are they unsure about whether or not the event definitively did or did not occur? And finally, they can check if it does not apply to them. The LEC interview version is a 12-page interview that is administered to the client. This version includes the same 17 traumatic events, but goes into detail by prompting the interviewer to ask follow-up questions for any positive response to any of the events the client reports that occurred to them. This is a more exhaustive version and may need to be administered in its own time, completely separate from the CAPS-5. The extended version of the LEC includes the 17-item checklist of potentially traumatic events, plus follow-up questions to help the interviewer determine if an event or a group of events satisfies the definition of a traumatic event. For any of the previously mentioned versions of the LEC, whenever the clinician is administering the LEC, it needs to be introduced by explaining the purpose of the checklist, and the instructions at the top of the LEC need to be read as they are written. When completing the LEC, sometimes a clinician will see that the client checked that multiple events had taken place. Prior to beginning the administration of the CAPS, the clinician needs to identify with the client what the worst event was. This event will be used as the index event later on in the CAPS. So at any point in the CAPS, when you see worst event or index event mentioned, that is referring to the event that you determined with the client that was the worst event for them. That event will be used throughout the duration of the CAPS-5. Also, as mentioned initially, there are 3 versions of the CAPS-5 corresponding to different time periods: the past week version, the past month version, and the past month or worst month versions. The past month or worst month version, which we are using today, can be used to assess the severity of PTSD symptoms for any 30-day period over the course of the participant's lifetime, during which his or her symptoms were the worst. This version is the best for establishing a lifetime PTSD diagnosis. You can also, by using this version, determine whether or not they have a current diagnosis if they reported that the symptoms were also active the past 30 days. So, for the purpose of practicing the CAPS administration today, you will have an LEC-5 standard version checklist that will be pre-filled out and that will help you establish criterion A in the CAPS. And you will have a blank new CAPS-5 past month, worst month version to use during administration of the instrument to your subject. It comes as no surprise that discussing traumatic events and the impact they have had on the person can be distressing. There are some essential skills that should be considered when administering any trauma assessment, including the CAPS. As with any instrument administration, it is exceptionally true that it is important to develop rapport with the client and maintain an effective alliance throughout this particular trauma assessment, as discussing trauma is globally a very difficult thing to do. A supportive and encouraging interview tone is essential, in addition to discussing matters of privacy and confidentiality, especially due to the sensitive subject matter. You can also ask the client about any concerns they may have before getting started and addressing these concerns off the bat. Let the interviewee know that there are no right or wrong answers and encourage them to give specific answers to specific questions. While specificity is encouraged, it is also important to facilitate this instrument while maintaining structure and keeping the interview moving along, as it can be distressing for clients who spend too much time discussing any particular symptom that has to do with a traumatic event in their life. In terms of the interview structure, let the client know that the length of the time it typically takes to complete the CAPS is about 35 to 45 minutes, although as previously mentioned, it can take up to 60 minutes. if the client takes their time or you have to attend to them if some of the questions become a bit too distressing. The purpose of the findings must also be disclosed to the client. For example, if the CAPS-5 will be used for treatment planning purposes later on, for clarification of a PTSD diagnosis, or for a disability determination, etc. And again, informing the client of potentially stressful experiences while encouraging them that the stress may pass is essential when introducing the CAPS-5. Let them know to keep open communication with you throughout the administration of the instrument, and remind them of their right to withdraw consent at any time if they notice that the experience is becoming too distressful for them to continue.